characteristic imaging findings.
Abdominal vascular syndromes, characteristic imaging findings. The common abdominal vascular syndromes are median arcuate ligament syndrome, Wilkie syndrome, congenital and acquired, nutcracker anterior and posterior, May-Turner syndrome, uretero-pelvic junction obstruction by renal vessel, ureteral vascular compression syndromes, portal biliopathy. Common symptoms of these syndromes with a common and overlying GI symptoms between them: median arcuate ligament syndrome, characterized by difficulty in breathing, nutcracker syndrome, left flank pain and hematuria, superior mesenteric artery syndrome, gastroparesis and GI obstruction, May-Turner syndrome, chronic venous insufficiency, and the overlapping GI symptoms. Median arcuate ligament syndrome could be due to higher origin of the celiac artery, lower insertion of a median arcuate ligament. What happens? During expiration, the compression of the ligament increases, so we need dynamic imaging, and it's very important. Arterial phase acquired during expiration and portovenous phase during inspiration, the hooked appearance of celiac artery in sagittal images, post-stenotic dilatation of the celiac artery, median arcuate ligament more than 4 mm, plus or minus pancreatico-duodenal artery collaterals. What is the differential in our case? Calcific and atherosclerotic plaques, but the hooked appearance of the celiac artery confirms the syndromic cause. What to look for? As a sequelae, pancreatico-duodenal artery could have aneurysms and complicated by hemorrhages. The patients in danger, in this case, the patients that will undergo pancreatic surgery, there will be no pancreatico-duodenal artery, and they will suffer infarctions as the celiac artery will be the main supplier. This is a case from our department showing the celiac artery with hooked appearance with the post-stenotic dilatation by 10.9 mm and pre-stenotic stenosis 6.5 mm. In a healthy patient, sufficient fat with third part of the duodenum and the left renal vein is seen between the aorta and superior mesenteric artery. In the nutcracker phenomena, the patient lost weight like in anorexia nervosa and with no compression sequelae or clinical symptoms. In Wilkie syndrome, it's characterized by third part duodenum obstruction and dilatation. In nutcracker syndrome, left renal vein compression and post-dilatation with pelvic venous congestion, mainly left-sided, and hematuria, which is characterized in this case by non-glomerular type. Nutcracker syndrome, it's two types, anterior nutcracker and posterior nutcracker. Anterior nutcracker is the compression of the left renal vein with a big sign between the aorta and superior mesenteric artery. The posterior nutcracker is the compression of the retroaortic renal vein behind the aorta. These two figures showing the normal angle range around 45 degrees, which normal range between 38 degrees and 65 degrees, less than 35 degrees is diagnostic, and the normal aortomesenteric distance from 10 to 34 and 2 to 8 mm is diagnostic. As for a left renal vein, ratio between the aortomesenteric renal vein and the hilar or the dilated renal vein more than 4.9 is diagnostic, as seen in figure 3A and 3B. The ratio here is 5. Case from our department showing decreased aortomesenteric angle 3.6 mm, and the angle is decreased seen 17 degrees. As for the Wilkie syndrome, this is case from our department showing the decreased angle up to 11 degrees with dilated duodenum reaching 4 centimeters, and the duodenum is seen compressed between the aorta and the superior mesenteric artery. This the case, the decreased distance of the aortomesenteric distance reaching 1.9 mm. May-Turner syndrome, it's the compression of the left common iliac vein between the right common iliac artery and the vertebral body, and it's, there is another type with less common, right common iliac vein compressed by the right common iliac artery. A Doppler ultrasound is the best modality in this case. It shows the deep venous reflux in the vein, associated varicose veins, post-thrombotic May-Turner syndrome, and any other cause that, of compression that excludes the syndromic cause. These figures, in figure A showing the flattened left common iliac vein, in figure B showing thrombosed left common iliac vein, in figure C showed compressed against the spine, and showing stenosis more than 50% of the lumen is diagnostic of May-Turner syndrome. Ureteral vascular compression syndromes. It's seen compression in ovarian vein syndrome, and it's due to hormonal changes or pregnancy, more common in thin women, post-thrombosis, but not pelvic venous congestion syndrome, which is dilatation that extends caudally till the parauterine vessels. Compression by the common iliac artery aneurysm, compression of the ureter by the inferior vena cava in the retrocaval ureter as shown in figure C. Pelviureteric junction obstruction due to crossing of vessels. If there is accessory right renal artery and any lower polar segmental renal vessels, it will cause in some cases obstruction في pelviureteric junction. Portal bilopathy, it's biliary obstruction that is associated with cavernous transformation of the portal vein due to portal vein thrombosis. Stricture formation is a well-known complication, as we seen here the cavernous transformation in the figures shown. Portal cavernoma is the cavernous transformation of the venous drainage of the common bile duct formed by the paracoelidocal veins and the epicoelidocal veins located along the ductal wall. There are two mechanisms responsible for the portal bilopathy: an outer mechanism, mechanical compression of the biliary system by portal cavernous transformation and/or peribiliary fibrosis secondary to inflammatory or ischemic change caused by thrombosis small veins in the bile duct walls. It's classified into three types: varicoid, fibrotic, and mixed. The varicoid type is the compression and distortion of the bile duct caused by large collateral veins. The fibrotic type shows the thickening and narrowing of the bile duct resulting from the compression of smaller intramural collateral veins. And this table to summarize the compression syndromes, the causes and clinical features and CT key findings and the proposed treatment. This is the continuity of the table showing ureteropelvic junction obstruction and ureteral vascular compression with portal biopsy, also to summarize the cause with clinical picture with imaging with treatment. Thank you.
شكرا دكتورة سارة. الكومنت.
أنا عندي تعليق بس.
دكتورة
ثانية يا سارة، ثانية دقيقة واحدة. هو في تعليق على النت كراكر سندروم. لو أنا شفت الإيمجينج فايندينجز بتاعتها والعيان ما عندوش أي سيمتومز،
لا بنقول إن هو فينومينا.
أقول عليها فينومينا ويبقى مكتوبة في الريبورت إنها فينومينا على أساس بعد كده لو. طب عيان عنده يعني حابين عليها ليفت لوين بين هيماتوريا سندروم، ايه الحاجات اللي ممكن اعملها له تو سجست نوت كراكر قبل ما اعمل الراديولوجي، قبل ما اعمل الايمجينج؟ يعني حاجه في المعمل وحاجه انفيزيف.
هو في المعمل اهم حاجه عندهم بيبقى التايب اوف هيماتوريا بيبقى لو هو جلوميريولر.
لا في التيست اسمه ايه اللي بطلبه؟ فيز كونتراست مايكروسكوبي.
اوكي.
ده هيبين ان هي نورمومورفيك ار بي سيز او ديسمورفيك جلوميرولار اوريجين. فبطلب فيز كونتراست مايكروسكوبي. طب في الحاجه الانفيزيف بقى اعملها له؟
هو الانفيزيف ما فيش غير الكونفنشنال انجيوجرافي.
لا انا بتكلم قبل الاشعه، لا اعمل له سيستوسكوبي.
اوكي ممكن.
سيستوسكوبي هلاقي فيه ايه؟ بلادي افلكس من الليفت يوريتر. ده يبقى ده ماشي مع انه ليفت جاي من الليفت سايد. تمام. شكرا جزيلا.
شكرا.
طب ممكن انا اقول لحضرتك كومنت برضو بقى على الويل